Anyway, let's go back to history and recognition. We're going to talk about recognition, deep endometriosis, what the laparoscopic appearance of a 0.080 millimeter lesion is, 80 microns, you can see them laparoscopically, and look-alike lesions. I have no current conflicts of interest. I'm going into a venture with luminous CO2 lasers next month on the chance that they and I will work out something on education and research. For those of you who want links to some of the material that's going to be here, that's the link. If you just remember danmartinmd.com, it's the third link on that page for the next week or two until we change it. We're going to start with William Russell, 1899. He was taken out of cancer in the left ovary. He found that in the right ovary it looked normal but was grossly covered in adhesions. And what he found in there, if you can look at those circles, the circle in the middle is endometriosis near the hilar vessels. The other circles are endometriosis in the adhesions, which he had not noticed at the time of surgery. The adhesions areas are microscopic. If he cut through the ovaries, the one in the middle is macroscopic. But this is unseen endometriosis that he could not see in adhesions at the time of surgery. First recorded thing I know of someone who found it histologically but didn't see it. John Sampson found the same thing, but when he was talking about adhesions, we'll show you slides in a moment, he was talking adhesions from the rectum to the cervix. So he's talking about the cul-de-sacs completely obliterated. And if we look at those pictures, when somebody talks about classical endometriosis, that's classical. The entire pouch of Douglas is gone. The bowel is adherent to the back of the cervix, back of the uterus. This is all the way since 1903. If you look at the descriptions from Rokitansky in 1860, it's the same descriptions. Classical is deep infiltrating rectovaginal endometriosis in the area of the pouch of Douglas, not in the septum. In spite of what they say in the textbooks, it almost never gets to the base, to the level, normal level of the septum. It's always in the area of the cul-de-sac. Now, I was privileged to live 2 hours away from Pete Hollis. So Pete's born in 1937, born in Amory, Mississippi, little town of 7,000. It's about 2 hours from Memphis, 3 hours from the University of Mississippi at Jackson. He becomes American College president from a rural area in 1993. But let's go back to 1985, because in 85, I'd already published my first paper on excision. And he had sent a patient to me because he'd felt a left uterosacral nodule. He knows it's there. He sends her to me because he knows how to do it at laparotomy. And that day and time, this was a laparotomy thing. He wants to see if I can do it at a laparoscope. So he sends her to me. I excise it, get histologic confirmation. We're all happy. Send it back to her. Pain's still there. He examines her. Nodule's still there. And we'll show you similar nodules later on. But he sends her back to me and tells me to get it this time and tells me what to do. Because he's been operating forever, he knows exactly what to do and why I missed it. And he says, you examine her before the excision to make sure you know where it is. When you get in, you push it up with the finger, one finger. This is before David decides he's a one-finger examiner. Pete Hollis knew that. You push it up into the field, and I'll show you pushing one up later on. Then after you've excised it, examine her again, make sure it's gone. You don't miss them if you do that. Which brings up several papers that Pete, Harry Rich, and Gordon Davis helped me produce. The middle one, they're actually acknowledged. I should have acknowledged them in all three. It's the deep excisional paper in 87, the laparoscopic vaginal colpotomy in 88. We'll talk about that more. And the 5 millimeter definition of deep in 1989. All those came out of that research. So Philippe Konix in Belgium recognized that if you do a menstrual exam, you pick up nodules more than if you do an untimed exam, significantly more. After that, though, he realized that when he did a laparoscopy on them, some of those appeared normal, even though he knew that there was a nodule there. If we look more at that, okay, back up, excuse me, I got ahead a slide or two. So I was lucky enough in 1981 to attend lectures by Maurice Bruja from Clermont-Ferrand and Kurt Sims from Kiel, Germany. Kurt presented at the 10th annual AAGL meeting in Phoenix, Arizona, and Maurice Bruja presented at one of Dr. Bellina's conferences in New Orleans. By this point in time, Bruja has been doing laparoscopic infertility surgery since 1977, and Kurt Sims had already published excision in 1980. So excision's not new. It doesn't belong to anybody who's in this room. Excision was first started by people who were no longer alive. At laparoscopy, excision at laparotomy had been around for 100 years. But Kurt Sims in 1980 had published an article that said that nodules were too large to be coagulated. And he presents in the 1981 meeting his slides on why he did excision. And he was just doing partial excision then. He just wanted to get it small enough so he could coagulate it, presents that, and Bruja presents his article on how to use a laser. And after that, it was off and running because I was hooked. One of the first papers in 1988 was similar to what Dr. Adamian talks about in terms of her grade 1, grade 2, stage 1, stage 2 lesions up at the top, where the lesion is basically retrocervical and does not involve the bowel. So if it's retrocervical and doesn't involve the bowel, you can remove it laparoscopically. So right there in the retrocervical area, Adamian stage 1 involves just the retrocervical area with no extension toward the rectum, and stage 2 extends toward the rectum. Not new. This was known in the deep cul-de-sac behind the cervix since, it's building, wait till it finishes building. I'll figure out, there we go. Cullen in 1917 has published that, so there's nothing new about that lesion. And his drawing in 1917, you can see he already knows illustrations of retrocervical endometriosis that doesn't involve the rectum. So Kurt Sims, in his textbook in 1984, is going to use a laparoscope so he can safely excise them vaginally. So in our first episodes of using a laparoscope to excise these, it's being used to guide vaginal surgery. But if we look at what we did in the laparoscope, this is 1986, that's the same lesion they've been looking at. It's a retrocervical lesion. It is larger as you go after it. The surface is the smallest area. So as you go deeper into it, you get to see it. So that's in between the uterosacrals. As you see there, the rectum's getting up toward the uterosacrals. You worry about cul-de-sac obliteration. So you do have to believe Harry. Harry, you tell me to do what right now? What do I want to do right now? Put your finger in the rectum. Yeah, put your finger in the rectum, yeah. And what else? Put a sponge force up there and make sure you can see it. Yep. Harry's basic rules, get a sponge forceps in there so you can see everything. As I said, Harry helped develop these techniques. So we first get the excision, and then you can see the fibrotic endometriosis and the healthy fat. For those of you who aren't used to looking at fibrotic endometriosis and healthy fat, let me put a ring around it. So that's the fibrotic endometriosis, healthy fats at the rim, and then the peritoneum. So you understand, excision for me in that point in time is CO2 laser. So these are all laser incisions. Now, so you can tell where it is. Now we go back to Harry's basic rule, that Forster forceps is your friend. So you put a forceps in there, a little circle in the middle, that's the widest area, that's the tip of the forceps in the vagina, and that fibrotic endometriosis is sitting right on top of it. Once you get that view, then it's fairly easy to take that endometriosis off the vagina without entering the vagina. But until you get that view so that you have the thing sitting up, it's hard to know where to go. And this was the same thing that happened with that lesion with Pete Hollis's patient. We didn't push it high enough up to see it. I tried to go after it instead of bringing it to me. So for those of you who aren't doing stage 3, stage 4 rectovaginal endometriosis, for those of you who are still doing stage 1 and 2, this is the kind of thing you need to know. Now, here we go. This one's slightly different. The rectum is right immediately adjacent to the cervix at the level of the uterosacrals. Now here's my question for the audience. Those of you like Harry do not get to answer. David doesn't get to answer. Gary doesn't get to answer. You already know the answer to this one. Okay, for those of you who've never had to operate on this, that is the tip of a stage 4 lesion. So what you see there at the top of this is that little circle at the top there, that red circle. The yellow we'll talk about in a second, but the red is all you see and all that other stuff is behind it. Just to notice, we'll talk about this later because it comes up in another slide, that yellow highlighted area is where this either infiltrates into the cervix, or if you believe Jacques Donnet, it starts in the cervix and infiltrates toward the rectum. We'll spot you on which one of those you want to believe, but there are two different beliefs on that. But for the moment, all we see is that thing at the top. Okay, for those of you who have not done this surgery, how many of you want to start and try and get that off the bowel at point 2? And how many of you want to take it off the top at point 1? So let's have a vote. How many of you start at point 1? Oh, David, do not believe David. He already knows the answer. How about point 2? And what happens if you start at point 2? You get to see the longitudinal muscle of the bowel. So this is, again, 1985, 1986, before we know all this stuff. So when you see, I know. Like I said, this is 1985, 1986, before you and I have even met. 85. So when you see these lesions where everything is plastered together, you've got to get it off the cervix first. And I really think the best idea is come in vaginally and get it off the vagina first. I like that idea. That worked really well the few times we tried it. Then you get to the deeper lesions. Here's one coming through the back of the vagina. And the interesting thing is that the first 7 patients we did like this, 5 did not have rectal involvement. Coming through the back of the vagina, 2 had rectal involvement, 5 did not. So if the 5 did not, here's one of them. Whole posterior thing, that little whitish lesion in the middle is the one we're going after. And in the dissection, if you look carefully at the lower part of that plug that we're taking out, you can see healthy fat. But at the top, you see the fibrotic endometriosis. And you see the fibrotic endometriosis because on this one, I got lucky not to cut into the back of the cervix any deeper than that. You can see I cut across the endometriosis, but I didn't take the cervix apart. Later on, I actually went after one all the way into the cervix, took the cervix off posteriorly, got into the endocervical canal, had to open her and repair the cervix. And this doesn't make the MFM people happy. They don't like it when the patients are missing 1/3 of their cervix. But when you look at that histologically, you can see the same thing histologically. The vagina's on the far left, peritoneum's on the far right. We have healthy fat at the base, but we've cut into the endometriosis at the upper cervix on the back of the cervix. So when it goes into the cervix, don't try to track it. You're not going to get it all unless you take off the entire back of the cervix. Then you worry about premature labor, prematurity, putting babies in intensive care units, all those kind of things. So trying to go after all the endometriosis in those cases, we won't do. Now, is Dr. Vidal, I didn't even look to see if he's here. Is he here today? Vidali? No, he's New York doc. Anyway, this is on YouTube. For those who haven't seen this, I think for recognition, this is a nice video. It's been up for about a month. The link is down there. The link will be on the website that I told you earlier. But when I first saw that and he's about to do this procedure, I decided I can see what he's going after. He's going after that residual ovary right there. And I'm sure that's the residual ovary. It's obvious to me it's a residual ovary. And then all of a sudden he starts going after that. That's the residual ovary. And it's almost impossible to look at that first slide for me to know that that is the whole thing until he gets it done. You can see how that whole ovary is being flapped down. So until you get behind it and cut into healthy tissue and start dissecting in healthy tissue planes, you really don't see the ovary. He saw it, I didn't. Teenage endometriosis, completely different thing. If you look in there, we see those little lesions, little 400 micron lesion that has glands and stroma, little 200 micron lesion that has glands only and no stroma. But what's remarkable on that picture, and we didn't know before we looked at Dr. Roman's pictures, and Roman will be here tomorrow, when he starts seeing lesions down at the 50 micron level, we went back and blew up these pictures, and that lesion at the very top is what a 0.08 millimeter lesion, 80 micron lesion looks like laparoscopically. Now, at the time we didn't know this, so we didn't histologically prove it. It has all the other characteristics of the other lesions. I conclude that it's one too. But to prove that, we'd have had, this whole specimen here is less than a centimeter in size. We're sitting right on top of it with the laparoscope. So to cut through that, to verify that, you'd have had to do somewhere between 150 to 900 sections to prove what that was. That is economically not going to happen unless you've got a research grant to do it. Second, not only is it economically unfeasible, but we can't prove that there's a reason to do it. There is no proof that other than for scientific inquiry that there's a reason to document that lesion. We'll talk about that more later. How many of you have seen this slide? This slide's been used for years. How many have seen this slide? Okay, for those of you who've seen it, how many dark scarred lesions do you see there? Does anybody see the second one? Yeah, down below. No, that big one's at Bowel, but there's a small one down below. Dark scarred one down below on the uterus. So what's that on top of? So to your left is the ureter, to the right is the ovary. So what's that round structure that's sitting on top of? That's the ureter. Okay, so we're sitting on top of a ureter. So you got two dark scarred lesions on top of the ureter. How about vesicular lesions? How many? Two. And then how many areas of abnormal peritoneum? Another 10 that you can count, probably more than that. So if you look at this thing, that red one is around the second dark scarred lesion. I looked at that slide for 5 years before I saw that. And then the two vesicular lesions, about the same thing. And then for David's type lesions, when you start talking about abnormal peritoneum, it's all of those. And if we let David look at it, he'll probably find a few more. I think he's going to show my dandelion slide just to embarrass me later today, but that's okay. David sees things that most of us will never see. I didn't see it on the dandelions. Now, let's talk about histology for a second on all those, because what I said earlier is I don't have data that says that we even need to do documentation at that level. Histology is to histology is to evaluate disease. Histology is not to exclude endometriosis. If you see a 1 millimeter lesion, your pathologist should be able to tell you whether it's cancer, lumpal potential tumor, endometriosis, psammoma bodies, mesothelial proliferation, lymphoid aggregates, and on and on and on and on. They should give you a diagnosis. Do we have a pathologist in here? Yes, you can figure those out, can't you? If I get the tissue to you, you got the answer. When you get a negative slide from a pathologist, that means that somebody screwed up before it ever got to the pathologist. Either you didn't sample it right, the nurses didn't handle it right getting it off the table, the cutters didn't cut it or submit it right, but if it gets to the pathologist, they can nail this stuff. So if you're getting negative histology, there is a problem on the line before it gets to the pathologist. Pathologists don't miss this kind of thing. Negative histology is indeterminate. It tells you nothing. You get a negative histology or somebody who says no evidence of endometriosis, that is no information at all. If you take the time to do it, the only times you're not going to get the pathologist to tell you what it is when you lose the specimen because it's too large, too small. Now, here comes the reward. I have never seen a paper that shows that we get statistically significant differences in outcomes based on histology positive and histology negative tissue. We've had this $100 reward up since 2008 at World Congress of Endometriosis in Melbourne. I want one of you guys to take my $100. Show me that paper. Show me that anything that histology, other than ruling out cancer and low malignant potential tumor and evaluating other diseases, show me that histology just to confirm endometriosis is meaningful. It makes me happy. I enjoyed the research. It made David happy. He enjoyed the research. A lot of us enjoyed the research, but so far we don't have a paper that tells us what it did. And if anybody gets it approved by clinicaltrials.gov, you get $200. Okay? Most Americans don't quite get clinicaltrials.gov. The only gynecologists I know who have papers approved in that who aren't PhDs, we'll spot you guys. You guys do this all the time. But all the surgery-oriented people are all Europeans. They know about it. We don't know about it. So now we get back to CO2 laser vaporization. How many of you think that's endometriosis? Raise your hands. How many of you think it's something other than endometriosis? Okay. Now, how many of you think that's something other than endometriosis? That's a carbon briquette on top. How many of you think it's endometriosis now? Come on, David, you get your chance.
It's down there below it.
There you go. Carbon's on the top. So laser vaporization, particularly at this level, if you get down to 50 to 400 watts per square centimeter, you're not using a laser, you're using a blowtorch. It doesn't get the job done. It just carbonizes the tissue on top, hides it at the time of surgery, and then later it's hard to see. So like David says, there's our endometriosis in the bottom right-hand corner. So you don't want to use vaporization very often. I wouldn't use it. We quit using it after a while because it had this kind of effect too much. We went back to excision. Excision has the advantage of being able to see what's going on. So in this picture, we've got the rectum on the bottom left, the uterosacral is up above us. We have a little black lesion that everybody can see, and the opening to a pocket. So we first open up the pocket, and you get to see the pocket back behind there with some old hemosiderin and debris in there with the endometriosis. Then we open up the second one. So we take that black lesion off, and we find an unexpected pocket back behind that. And then we resect both of them. And that's what a high power density laser at about 5,000 to 10,000 watts per square centimeter is capable of doing. You can get clean excisions, you can take things off, you can save the blood vessels. David does the same thing with monopolar electrosurgery. And in this day and time, I would not go back to a CO2 laser because it's too hard to train somebody to do that. This equipment's relatively unavailable, and the equipment David uses is available in the entire everywhere. So David does this with monopolar electrosurgery, gets the same job done. It's a lot less expensive. I'd stick with it. Just a few little things to go along with this. Remember, if you look at these dark lesions that the pathologist can't prove, you're telling them the wrong thing. Those vesicles are the endometriosis. The brown is hemosiderin. It's peritoneum hemosiderin. And if you look at those, the vesicles are glands with a little bit of stroma. If you look at the brown, if you look in that middle picture, if you look hard enough, you can see the hemosiderin on an H&E stain, but you need iron stains. So just tell your pathologist, it's got brown peritoneum, it's full of iron, we need iron stains. They'll do Mallory or something else. And then instead of a little bit of hemosiderin, the whole area lights up with iron. Last series of things to talk about, look-alike lesions. This patient had already been on danazol for her endometriosis. She was sent to me. She's got hemangiomas. For all practical purposes, looks like endometriosis. This one had been on danazol for endometriosis. These are all 1980s. Danazol was a big deal then. This one's been on danazol for her endometriosis. That's Samoma bodies. Those kind of lesions also look exactly like low malignant potential tumor. So if you see clusters of vesicles, you see fleshy looking appearances, you see solid white nodules, make sure you get histology on those. Those are the ones we worry about, particularly like that. That's metastatic breast cancer. So we really don't like white nodules. Thank you, and we'll go to questions. Yes, sir.
I have a couple comments.
No, you don't get to comment until later today.
Okay.
We're going to ban you.
We learn in Googling endometriosis that Robert Barnes described exam during menstruation in 1873.
Okay.
And the single digit exam that you're talking about is what was called vaginal touch by the French in the mid 1800s. So, you know,
Yeah.
those things have been around for quite a while.
Long time. But you speak French, I don't.
Mais certainement.
See. Da.
Tamam.
I'd just like to say that the most forgotten entity in diagnosing endometriosis is a rectovaginal exam. Every patient with pain should have a rectovaginal exam, so you know what you're getting into when you do surgery. Where the patient hurts, that's the area, in most cases, that you want to excise.
So Harry and I have disagreed on this for a while. If on vaginal exam with one finger, if you haven't already found everything you're going to find on rectovaginal exam, you need to improve your vaginal exam skills. Because you're closer to the lesion vaginally than you are rectally.
Dan, I've never ordered MRIs or CT scans.
I didn't
Just-
either, but we didn't have
Just
them.
that one finger exam
back
will
in the
tell
days
you the
of
tale.
back in the days the dinosaurs were, we didn't have MRIs.
Didn't need it.
We, yeah, whether we needed them or not's a different question. I've watched what these people are doing with them now, and they know a whole lot more than you and I ever knew.
Time for one more question.
I said that is sometimes good that agree to disagree, but we do a lot of sonograms, preoperative sonograms with bowel preparation, and we can identify those lesions completely. And sometimes I'm doing the surgery, I cannot find the lesion, I call my sonographist. She
Yes.
go to the OR, do the sonogram, she found the lesion, and I go for it, and we take the lesion out.
Sure.
So on these days, we have the sonogram, and it has been very, very good benefit for our patients.
Yes. What's just a point of interest? What's the smallest lesion that you've seen on a sonogram now?
We could see lesions 3 to 4 millimeters
Yeah.
in the vaginal
Yeah,
cup.
yeah. There's literature on that. I was just wondering how much. We're waiting to see if you guys can start doing microscopic lesions with the sonogram.
No,
This would be
I
good.
don't think so, but we can see that
Yeah.
it's some retraction.
But three.
We can predict the complexity of the surgery. So we know, I called the gynecologist and said to him, it's going to be a difficult one. If you're going to enter with a colorectal or a gene-onco surgeon.
There was a recent paper about thickening and swelling in that area. Do you use that sign also?
Of the uterosacral ligaments?
Yes.
Yes.
Uh-huh. Yeah. Thank you.
Thank you.
Dan, you said you're not going to excise those lesions anyway, so why do it?
I didn't say, no. Once I'm in surgery and I see something, it's gone. It's going to go. Because I'm not going to wait on histology. That's a prospective question. I'm talking about retrospectively.
Tiny little things we used to call bullshit endometriosis.
We're still not sure what they mean, right? I mean, we've got data that shows that the volume and depth of endometriosis is related to the number of patients who have tender nodules. Really small lesions are less likely to be tender than large lesions. We have other long-term clinical observations that say we can't look at it. It's a pimple thing. You can't look at endometriosis and say how bad it is. It's just like looking at pimples. You can tell which pimple hurts. Excuse me. You can see which pimple is ugly. You can't tell which pimple hurts. Same model. So when you're looking at it, you don't know what it is. So if I'm in surgery and I see it, it's going to go. That's a different question.
But I just one more comment before, I'm sorry. I just have to add, all poking around, joking around, apart from that, we have to have realistic expectation with what we can find by pelvic exam and sonograms and everything.
Yes.
It doesn't show everything. There's
Yes.
always high lesion on the sigmoid, ileocecal, appendix. Will never show unless you see it, and you should be prepared to do everything in that session. You should have a team approach to the surgery. It's not like 20 years, 30 years right now. Patients do not need multiple surgeries. The team has to be able to handle everything. In our repeat surgery, we see quite a bit miss high lesions on sigmoid and ileocecal areas and pelvic side walls.
That's
And
going
it
to
doesn't
be,
show up in pelvic exam. It doesn't. Cervix is not that tender. Rectovaginal exam is negative.
okay. So let's talk about outside of New York City in specific. Let's go out into rural New York. Let's go into northern rural Mississippi. If you can get in rural northern Mississippi patients who have Medicare, Medicaid if they're lucky and got nothing else, then, and you can send them to you in New York and you're going to accept Tennessee Medicaid, okay? Then I'm all for you. And Tennessee Medicare, Medicaid, Medicare. Which one am I on? The one I'm not on.
Medicaid.
Okay. So if you accept the other one, then what you say is true. But if the rural Mississippi patients are going to have to be taken care of by rural Mississippi doctors, there's no way in the world that they can set their ORs up the way you set up. So you're talking about local, I mean, we were talking about the Beamer dealerships. So nationally, you need the Beamer index to decide how many IVF units you can have. Okay? You can't have more IVF dealerships than you have Beamer dealerships. Okay. So, but in New York, it's not the Beamer deal. It's not the Beamer thing. It's the Ferrari index.
Harry,
Different
let's
world.
continue the conversation offline.